is Lourdes. I am one of the case managers and the OJS lead. Today, we have a very special instructor. How can I introduce our speaker for today? Well, he has been a Care Center member since 2012. He completed the York University Bridging for IENs, and he's one of the members in Hamilton office. And he is my go-to person every time I need someone to help one of our IENs in that location. He's a big supporter of Care Center. And in 2015, he is the recipient of the Joan Lesman Award for IENs at Care Center. I'm sure a lot of you are familiar with that award. And I'm proud of him and his accomplishments. He is now a registered nurse, currently working as a manager of clinical practice in the region of Niagara. He is also an adjunct clinical instructor and a research assistant at Nipissing University. His main focus is geriatric and mental health nursing, and he has a lot of experience in the long-term care setting. So let us all welcome Alex Lamson. Hi, Alex.
Hi, Lourdes. Thank you so much for the introduction. But first of all, I think I owe a lot of thanks to Care. As a Care member, I came here in Canada in 2012, and as you probably experienced, we have difficulty at that time looking for resources and credible individuals to help us with our career track, and Care was very significant in terms of providing those resources and information to help us integrate to the Canadian healthcare setting. And I've known Lourdes for quite a long time, and she was integral in my success to get my license as an RN, and Adila for my RPN license. And in general, Care is very integral in terms of providing support to IENs in Ontario. So thank you, Care. Thank you, Lourdes.
We are all, it's our pleasure to support you.
Let me try if I can share. Challenges of technology. Let me find my PowerPoint. I hope this is the one. Are you able to see my screen?
Yes, we could.
Oh, perfect. Thank you. So welcome, everyone, and thank you for dedicating your Friday morning with me and Care in terms of discussing what are the essential skills that we have to develop and acquire when we start working in long-term care. As Lourdes mentioned, I've been working in long-term care since late 2012, 2013. I've also worked in acute care, but I transitioned to seniors and mental health, which is aligned to my passion in long-term care and geriatric care. So before we start, I just wanted to acknowledge that we are situated in the territory of Erie, Neutral, Huron, Wendat, and Haudenosaunee and Mississaugas. This land is covered by dish with one spoon, one wampum belt covenant, which has an agreement between the Haudenosaunee and Anishinaabe to share and care for the resources around the Great Lakes. We further acknowledge that this land is covered by the between lake purchases in 1792 between the Crown and Mississaugas of the Credit First Nation. So our objectives for today is for us to understand the goals of the Long-Term Care Act, discuss Residents' Bill of Rights, provide background on Residents' Care Plan, understand Care Conference, enumerate and discuss nursing and personal services in long-term care, review nursing skills in long-term care, and review trends and issues in long-term care. But one of initial question is, why work in long-term care? If you could probably with the reaction icon in your Zoom, if you could probably or be so kind enough to probably raise your hand or use a thumbs up sign if you are currently working. Let me see if Bernadette said she's working. And how many of you are working in long-term care or wanted to work in long-term care? I saw quite a lot of raised hand option. So thank you very much for your participation. So why work in long-term care? As I've mentioned earlier, I've been working in long-term care since 2012. And I've developed a passion in long-term care, right? And again, it depends on where you would want to work, right? If you wanted to work if your passion is acute care and hospital, then sometimes our career track would geared us towards acute care and long-term care. Acute care and hospital-based care. But if your passion is about geriatric care, then most likely you will start working in long-term care. Again, the challenges in IENs is that we came in Canada and we have limited resources, we have limited connections, so we get the first job that we get, right? So sometimes most of the INs that I know started working in long-term care, they developed their nursing skills and they transition to different settings like hospital or community care, right? Again, initially their first step to develop their experience is long-term care. And long-term care, in terms of their demographic, most of them are stable, right? If you are working in long-term care homes, most of the residents are stable. But there are times that if you work in, say, for example, respite beds in long-term care or convalescent bed, most of them are post-acute because they came from the hospital or recently discharged from the hospital from, say, for example, a knee surgery, or they wanted to go to a long-term care home with a convalescent bed for them to be rehabilitated. Long-term care is heavily regulated in terms of the services that they have to offer, right? So what I mean about heavily regulated is that the and the regulation 7910 governs the practice of long-term care homes and also of their staff members. So you probably have heard long-term care in the news recently in the pandemic because of the quick cases of COVID-19. And you probably would always hear in the news that the ministry is involved in long-term care regulation because unlike the hospital, we are governed by the Ministry of Long-Term Care, right? So they would always come in to do their inspection for any complaints or any critical incident, which we will review in the next slides. So the long-term care is primarily the home for each residents, and it is operated so that it is the place where they may live with dignity and in security, safety, comfort, and have their physical, psychological, social, spiritual, and cultural needs adequately met. So to satisfy this fundamental principle of the regulation, the long-term care sector has been given the responsibility in many areas. So this includes providing appropriate living setting, staffing levels, quality of care, access to family support, and other community services. So the oversight of the homes by the Ministry of Long-Term Care and the Long-Term Care Act of 2007, which governs the process for placing individuals in the home. So you will probably hear me always mention residents, because that's residents is what we call clients or patients in long-term care. Because residents, we call them residents because that is their area of, that is their home, right? That would be their long-term home. The fundamental principle of the Act is that a long-term care home is to be operated so that it is a place where residents may live with dignity, as I've mentioned, their basic needs to be met, right? So all long-term care homes, regardless of their ownership, must comply with the requirements under the Act and the regulation. So if the home is not following the regulation or the home is not following the Act, their license can be revoked, right? So currently in Ontario, there are 626 long-term care homes that were operating in Ontario at the time. I think it was around, I think this particular statistics was 2020 after the results or audit by the Auditor General of Ontario for the preparedness of long-term care homes for COVID-19. Homes are operated either by for-profit or not-for-profit entities. So a for-profit long-term care could be Sienna, Chartwell, Rivera, Extendicare, right? A non-for-profit homes, they are independent homes. So it could be based on religious sector. So say, for example, in Hamilton, we have Shalom Village, which is operated by Jewish religious sector, or it could be an independent standalone long-term care. So we have 169. There are also 100 municipal homes. So say, for example, in Hamilton, there are 2 municipal long-term care homes operated by the city. In Niagara region, we operate 8 regional long-term care homes. And also in Toronto, they have around 11 municipal homes. So they receive the funding from the Ministry of Health, plus they receive a funding from the municipal health. So in terms of their funding, they have more funding than compared to for-profit or non-for-profit homes. The reason why we call them for-profit is that the ministry provides funding, the residents pay for their lodging, plus the ministry and then the money that they get from the resident, some of it goes to profit. That's why it's called for-profit home, right? So regardless of their ownership, They are expected to provide nursing and personal services, infection control and prevention, nutrition, recreation, and social activities. Okay, which again, during the pandemic, they are responsible for acquiring necessary supplies, equipment such as PPE, and staff to deliver different programs, which we will discuss in the next few slides. So each long-term care, again, as I mentioned earlier, is responsible to provide this particular funding, these particular programs. So the difference between a long-term care and a hospital is in terms of their bed classification, right? And the length of stay of residents. In the hospital, when you're when you recuperated, then they discharge you, right? If, say, for example, an individual is not safe to go back home, they could either be sent to a long-term care home or retirement home, or regardless of the level of care that they need, right? So in long-term care, there's two types of bed in long-term care. We have basic bed, semi-private, and private room. All right. What a basic bed means is that there's 2 bedroom accommodating 2 residents with a separate washroom, right? Way before, if you have an older long-term care building, a basic bed means there's 1 room, 1 big room with 4 residents bed. But because of the pandemic, because of COVID-19 transmission in long-term care, instead of 4 bedroom, they transitioned it into a 2 bedroom. A semi-private, it could be 1 bedroom, but they share a common washroom. Okay, a private room is 1 bedroom accommodating 1 resident with their own washroom. A short stay bed, it means that from the word itself, short stay, it could probably be limited to a 90-day 90-day bed. So an interim bed and convalescent bed is that the residents go into long-term care, stay there for 90 days, would want to be transferred to another long-term care bed or go to a retirement home, or while they are in the hospital, they applied for a short stay bed in long-term care because their house is being renovated for, say, for example, they wanted a ramp, they wanted to renovate their washroom to accommodate their wheelchair. There are, in Hamilton, for example, there are 3 long-term care homes that has convalescent beds on it. So what does a convalescent bed mean? So for individuals recovering after surgery or serious illness who require intensive support for a temporary period of time, residents in this bed are expected to return to the community within 90 days. So it is a it's just like a rehab unit in long-term care, but they are more stable because they are waiting for a discharge to the community, or they're waiting to, say, for example, be placed to another long-term care home. So I was working for a few years in a convalescent unit in a long-term care, and I've learned a lot of skills because residents in convalescent care have complex wounds. So we would do vac dressing, we would do dressings for any complicated wounds. So in terms of skills, even if you're working in long-term care, if they have a convalescent bed attached to it, you will still keep your nursing skills, because we would do IV, we would do different types of nursing skills that we basically don't do in a regular long-term care bed. Just feel free to let me know if you have any questions. Suni, you raised your hand. Okay.
No, it's okay. Thank you.
Okay. So currently we have 78,000 residents living in 626 long-term care homes, which typically operate to close to capacity. So say close to capacity means if a long-term care has 216 bed, so most likely there's 216 residents in that particular long-term care. Ontario's aging population. Ontario's aging population will likely increase the demand of safe long-term care homes and safe home care in the next 20 years. So according to Statistics Canada, the proportion of the population aged 65 and over in long-term care is projected to increase from 16.9% in 2018 to, guess what, 26.1% in 2043. According to a recent report, if my recollection is accurate, that in 2019, the medium wait for a long-term care placement is 152 days. So they would say, for example, they're in the hospital, they wanted to go to long-term care. Most of them wait for 152 days because of a high waiting period. So currently we have 37,000 people waiting to be placed in long-term care. Some of them probably is unable to wait because of their comorbidities or their complex need. That's why if you work in community, you might have this particular client for 3 months, and after that, they are placed in a long-term care, right? The complex needs of the resident have increased in the past 10 years. So my residence, say for example, when I started, is very different from, so I had residents who are still able to walk, able to do their personal care, but most of them is very independent. That was from 2012. But if you're going to compare your residents now in long-term care, they are more frail. They need extensive assistance. Most of them are in a wheelchair or walkers. And 64% of residents in long-term care have cognitive impairment. So it means that there's 1 to 3 residents with cognitive impairment or dementia or Alzheimer's. As I've mentioned earlier, I alluded to the number of beds. But in this slide, there are over 77,968 number of residents in long-term care. So most of them are female residents, and 54% are age 85 and over. In terms of the demographics, over the 11 years, the proportion of residents with complex care have increased. So say, for example, in the 2009 census, most of the residents have, so the proportions of residents with heart disease and dementia has increased by 14.3% and 12.5% respectively. So say, for example, in March 31, 2020 census, 75.9% of heart disease, 63% of them have dementia. And in diabetes, 28%, lung disease, 18.3%. So if you're going to compare the 63.2 to 14.3% from 2009 to 2020, then there's a big difference in terms of the number of residents who have cognitive impairment. And the average stay in long-term care is 2 years and 7 months, right? So you might have a resident who just get into long-term care for probably 2 days and sadly pass away, or you might have residents who've been there for 5, 7, 10 years, but still able or probably needed complex need. of the age of residence in long-term care and retirement home in developed countries. Canada, compared to the rest of the world, the average age of a resident in long-term care is 74 years old. Say, for example, in the United States, the average age is 54, right, in long-term care. According to the data from the Ministry of Long-Term Care's latest available staffing study, that was July of 2020, in 2018, over 82,500 people working in long-term care. Additional to 12,500 people are working as a cleaner or cook, cleaners or cook rather. So there's about 100,000 people working in long-term care. Personal workers and healthcare attendants, or PSWs, comprises the majority number of individuals working in long-term care. So we have 49,978. Right. So personal support workers are individuals who are responsible for assisting residents with their activities of daily living. So that would be bathing, eating, walking, perform light housekeeping, and tasks delegated by the registered health professionals. Right. So these are individuals who possess personal support certificate from an accredited college in Ontario, and the profession is unregulated. The next are RPNs, or registered practical nurses. So RPNs, they comprise 15,263. So these are professionals who care for residents. But again, the scope of practice of RPN and RN have changed, especially the RPN scope of practice. They completed post-secondary nursing program at the college level, or if you are a internationally educated nurse, the college can assess you and be eligible as an RPN. Allied professionals, there's the allied health professionals in long-term care are dietitians, occupational and physical therapy, social worker, or other providing support and administrative services. And they are professionals under different colleges. RNs, surprisingly, we have less number of RNs, right? There are 7,846. And nurse practitioners at 67. So we've discussed the regulation. We've also discussed the general demographics in long-term care. When you start working in long-term care, you'll be able to see the difference, right, of long-term care and acute care and also of the community. Long-Term Care Act of 2007 requires that each home have a person in the following position. So the first is administrator. So they are responsible for the home and the overall management of the organization. You also have the director of nursing and personal care, right? So the director of nursing and personal care needs to be a registered nurse who supervises and directs nursing staff and personal care. So she's responsible for registered staff, RN or RPN, and also of the personal support workers. The medical director is a physician who evaluates and addresses medical practices, clinical procedures, and resident care. So this individual is responsible for the physicians in the organization. So you might have one medical director who's also in charge with some residents in long-term care, or there's one medical director and two other physicians. However, the Long-Term Care Act do not prescribe the minimum staffing requirement beyond the ones that just noted. So, but that's require the homes to have a staffing plan in place that provides for a staffing mix that is consistent with the resident care and safety needs. So there are long-term care homes who only have one RN in the building who works as a charge nurse. And the registered staff giving medications are RPNs. So you're in charge with medication, doing the assessment, and when the resident develops any acute change or significant change in their condition, then they collaborate with the RN. The physician or nurse practitioners responsible for physical examinations on admission and annual physical exam, but they are also responsible for any other medical services that the resident might need. RNs are on duty 24/7. So the Act prescribed that there should be an RN who is not a member of the management staff to be available 24/7. That's why if you start working in long-term care, you'll be able to see that there's only one or two RN in a given shift. So that will be on days, evenings, and nights. I mentioned earlier that long-term care is heavily regulated. So in 2019, we have our own ministry, Ministry of Long-Term Care. We were initially attached with the Ministry of Health before 2019, but they wanted a separate ministry to oversee long-term care. So in June 2019, the province separated the responsibility of the former Ministry of Health and Long-Term Care into separate ministries. So the Ministry of Health and Ministry of Long-Term Care. The Ministry of Health sets the priorities for Ontario's health system, both public health and healthcare. So the patient ombudsman reports to the Minister of Health. The Ministry of Long-Term Care licenses and regulates long-term care homes, including conducting inspections required under the Act. And it also provides funding through local health integration network to long-term care homes for beds that are co-funded by the resident. So co-funded by resident means they co-pay. So the ministry would pay a portion of their rent, and then the resident have to pay the rest. The Long-Term Care Act of 2007, which came into effect on July 2010, and its Regulation 7910, sets standards for long-term care homes in Ontario. So the Act covers residents' right, care services, admission of residents, operation of homes, funding, and licensing of homes. So it also provides the Ministry of Long-Term Care through the ministry and the Minister of Long-Term Care with the power to inspect homes to ensure that they are complying with the legislation to take enforcement actions if necessary. So say, for example, you're driving, right, in the highway, and the regulation only says you need to be at a maximum of 100 kilometers per hour. If you go beyond 100, they will not immediately give you a ticket, right? So if you're more, say for example, if you're 105 kilometers per hour, they might still let you drive that way. But if you go beyond the threshold, which is, say for example, 130, 145, then they might probably give you a ticket, or they might suspend your license at that particular time, at that particular day, right? And that's how the ministry and the regulation works, right? So say, for example, there's a lot of complaint in a long-term care home. They will call the ministry will do an inspection, and they will identify during their inspection if you are compliant with the regulation. If you are not, then they will give you a warning. They will come back and do their inspection again. And if they identify the same error or same non-compliance, they will give you another warning. On the third, or it depends on the severity, right? And then when they say, okay, we've give you a lot of opportunities to rectify your non-compliance, now we will take over the home. So a director referral, it means that the ministry will be in charge of that particular home, or sometimes they will close the home for admission. So they would say, we will close your home for admission. You will not admit any residents until you rectify this error. Diana, did you raise your hand?
Yes, I would like to know how often are the inspections? Every 2 years? Or...
Before the Ford government came into power, we always expect for every year inspection. So we call that resident quality. An RQI means that a group of individuals from long-term care through the long-term care inspectors would go into the home and inspect everything in the long-term care. So it would be nursing, nutrition, dietary programs, maintenance, right? After the Ford government came into power, they don't generally do an year, only go to specific instances. I think we will discuss that in the next slide, and I will be able to explain it. So I'll get back to you. So it's very interesting that our funding is very different from the hospital, right? So the Ministry of Long-Term Care issues licenses to long-term care operators under the Act. So the terms can be up to 30 years. So they might give you a 10-year, they might give you 20, 25 to 30 years. It depends on the bed classification, right? So if your home, if the nursing home is built on before 1972, in order for you to be renewed, or in order for the home's license, you have to do renovations. Or say, for example, the ministry will say your building code or your building design is not on par on the current recommended design for long-term care. It's either they have to renovate the entire home, or they have to build a new building to satisfy the needs as per the regulation. In 2019-2020, a total of 6 billion was collected by long-term care homes. So 4.4 billion in ministry funding and 1.6 billion in resident copay. But this is important, right? In terms of residents' rent, so they have to pay $62.18 per day for a basic room. And it goes from 62.18 to 88.82 for a private. But regardless of your ability to pay for your room, you basically have the same services that you receive. So you still get 24/7 nursing care. You get 3 times a meal food which is important. So as I've mentioned earlier, how are we being funded? It's the occupancy rate. So if your home have 216 bed, then you multiply that to the number of residents on that particular day or that particular year rather, plus the type of bed that they have. Complexity, right? If your resident needs more care, then basically the province will give you more money, right? And also co-payments. So about 35% of residents in long-term care receive financial assistance from the ministry to pay for accommodation. So they would have to pay a certain amount based on the subsidized amount or coverage by the ministry. So say, for example, they have to pay 700, then the province might reduce that to only 200, or the province will cover all of the co-payment. Okay. A long-term care home is primarily the home for residents, right? And that is their home. And one of the important things that we have to remember is the residence bill of right. Because we are working in residence home, we are the guests, right? If you started working in long-term care. And residence bill of right is based on respect, based on providing security, safety, comfort of residents in long-term care. So there are about 27 Bill of Rights in the residence Bill of Rights. This is just a snapshot of the residence Bill of Rights. That they have to be treated with dignity and respect. They have the right for privacy. They have the right for information. That is why one of the things that I do when I go around is I check if staff are wearing their own name tags or name badges, because again, that is the right, that is one of the right of the resident, that they have the right to know who, or the right to know the individuals taking care of them. If you're new, you need to say, "Hi, Mrs. Smith, I'm Alex, I'm your nurse today," right? They also have the right to participate in making decision making. Again, that is general nursing that we ask consent. If the resident is unable to take care of, and make competent decisions, or they are incapacitated to make choices and decisions in their care, then we ask consent from the substitute decision maker. Right. And they also they also have the right to know their healthcare options and participate in their plan of care. That is why one of the important components in working in long-term care is care conferences. So if you become an RN or RPN, you might have to be involved in care conferences. If you became an RN in a long-term care, then there are times that you're responsible to lead care conferences. And one of the, if you start working, if they interview you rather in long-term care, that is one of the questions, right? How many Bill of Rights, and if you can enumerate at least 5 or 10 Bill of Rights. There was a question about how often or how will we know if the ministry will have to come into a home and do their inspection. The inspection is based on critical incidents, right? So critical incidents are occurrences that results to the harm or risk to the safety, security, welfare, and health of a resident, staff member, or a safety and security of the long-term care home. So the homes are required to report all critical incidents immediately. So what are the critical incidents that report? So we have to report immediately any emergency, such as fire or unplanned evacuation, sudden death or unexpected death of a resident, resident who is missing for 3 hours or more. If a resident is missing, then we have to, if we search the entire building, search the entire premises, then we have to call code yellow, right, which is missing patient or resident. Any missing residents who returned with an injury. So at one time, when I was working in long-term care, we have a resident who was missing, and we got a call from the police, and they said, "Is this one of your residents?" Because they saw them in a mall, right? And it was a significant walk, right? An outbreak of a reportable disease or communicable disease. So say, for example, you have 2 or more residents with the same symptoms of, say, for example, influenza, or say, for example, a GI outbreak. So you have to report it to the ministry. And we have our own reporting system. If you became a RN manager, or say, for example, an ADOC or assistant director of care or assistant director of nursing or director of nursing, then you are responsible to report any critical incidences to the ministry. And contamination of drinking water. We have to report that immediately. So if they call you at 2 p.m. of these particular incidences, then you need to do it in reporting. If it's a resident missing for less than 3 hours who returns to the home with no injury, an environmental hazard that affects the provision of care. So as simple as, say, for example, there's only one elevator in the building. If it's more than 3 hours, it's not working, then we have to do a critical incident. A missing or unaccounted for controlled substances. So say, for example, you are counting your narcotics before your shift ends, because one of the expectation, if you're working for 7 to 3, you have to reconcile the medications that you administered. So say, for example, you have Tylenol 3, you have Tylenol 2, you have morphine, hydromorph on your shift, right? You have medications that you administered, and also you have to reconcile that you have the accurate narcotic count, because we don't want any missing narcotic count, because number one, they are high alert medications, and number two, we don't want inappropriate use of high alert medications. So there are many instances, not many, sorry, there are few instances when we have to report missing narcotics, because, say, for example, yesterday the narcotic count for morphine is 16, but now when you count it, it's already 14. So we have 2 missing unaccounted narcotics. Either it was given, or we don't know what happened to the other 2, right? But most likely, probably it was given, but they forgot to sign the narcotic binder. And it was not also documented in the medication administration record. So we have to report that to the ministry. We have to call the police to investigate. And it's not only the city police, but we have to call the Ontario Provincial Police because it is federal. It is a federal mandate that we have to report any missing narcotic. So you don't call the city of Hamilton police. You have to call the provincial police, and they will have to investigate. It's a long paperwork, right? So if we do our 3 checks, then most likely we will avoid those recurrences or long paperwork. And medication incident or adverse drug reactions in respect of which a resident is taken to the hospital. So say, for example, it was a medication and resident was sent to the hospital, then we have to do a medication incident report plus a critical incident to the ministry. Now, if you have multiple critical incidences in your home, say, for example, there's 3 sudden deaths in a month, there's 15 missing unaccounted controlled substances in 3 months, then it will trigger a ministry visit. So when the ministry comes in, they will have to do their inspection on that particular critical incident. And from that, they would invest in compliant or following our policies and procedures. If we don't, and we are not following the policies and procedures, then most likely they have to give us a warning. As a registered staff in long-term care, you are also responsible to report any instances, right? So what we call mandatory reporting, because the regulations set out the requirements for reporting, investigating, and handling complaints. So including complaints of abuse and neglect of a resident. So the licensee must, or the home must report, respond, and act. So we have to report any improper or incompetent treatment or care of resident that resulted to the harm or risk of harm. Abuse of a resident by anyone or neglect by a staff or a licensee. Unlawful conduct resulted to the harm of the resident. Misappropriate or misuse or misappropriation of resident money, and misuse or misappropriation of funding. So say, for example, there's had the physical altercation in Friday at 4 p.m., then you have to call your supervisor and they will direct you on what to do, right? After hours, we call the ministry, right? So I'll discuss that further. One of the big things working in long-term care is knowing abuse and neglect, right? And reporting and investigation in the part of the RN or the RN manager. So there are 2 types of procedures for reporting suspected or witness abuse. You have to report it within your home, and we have to report the abuse to the Ministry of Long-Term Care. The decision about whether a long-term care report is required will depend on whether the circumstances of the alleged abuse or neglect meet the definition of abuse, right? So there are, as you know, there are different types of abuse, right? We have physical abuse, we have verbal abuse, we have financial, we have sexual abuse. It is an offense under the Long-Term Care Act to discourage or suppress any mandatory reporting. So that is why we are protected. If you don't feel comfortable in in the process that you have to notify your supervisors. And there's also whistleblowing policy in each home for disclosing any information to the Ministry of Long-Term Care. If the resident is harmed in any abuse and neglect, then it is the responsibility of the registered staff, RPN or RN, to notify the substitute decision maker or the family member if the resident consented, right? Say, for example, there's two residents fighting, there's physical altercation, then you have to notify both of the family members or their substitute decision maker. The substitute decision maker must be notified within 12 hours of the home being aware of any incidents. Again, because of increased complexity and increased cognitive impairment of residents in long-term care, then physical altercations might happen because of cognitive impairment, right? If there's physical altercation or there's abuse by a staff member to a resident or resident to resident or family member to a resident, we have to notify the police. So the police must be notified if an alleged or suspected or witnessed incident of abuse or neglect of a resident may constitute a criminal offense. So I'll give you an example. There's two residents fighting. The other resident was cognitive is happening. They are aware of the consequences of their actions. And we have a resident who have cognitive impairment. The other resident punched the other resident, right? We notified the police. The police called the family and they asked if they wanted to press charges. And the family said they wanted to press charges, right? So we have to move the other resident to another floor because there's a restraining order, right? Or there could be a staff member who intentionally caused harm to the resident. We call the police and the family complained of a crime. I think they made a complaint to the staff member, right? We also have to notify the Ministry of Labor if the staff member was injured because of an incident that resulted to harm, right? Say, for example, a resident who at that time was physically aggressive and say, for example, they had a physical contact with the staff and the staff got injured, then the Ministry of Labor have to be involved. Okay. So now if you have multiple incidences of abuse or any incidences that cause harm to the resident, the ministry will do their inspection, right? It depends on the degree of the harm of a particular resident. So if there's high incidences of abuse and resident injury, say for example, a resident fell, was sent to the hospital and had hip fracture or any type of fracture or any change in their condition, then the ministry will go into the home and do their inspection if we are following our due diligence, right, in investigating, mitigating, and ensuring safety for our residents. If you are a nurse working, say for example, in the evening or in the weekend, you have to notify the ministry. So you have to call their action line, and this is the common number. This is the number that we call, not the common, but this is the number that we call. So it is, I think I already memorized it. It's 1-866-434-0144. And we have to call them after hours to notify any incidences, because late reporting It's also it's mandated that we have to report immediately. Then if we don't report or late reporting, will also give us a citation. So the ministry would give us a warning for late reporting. Any questions? No? So I think we've discussed a drive portion of long-term care, but that is very important, right? When I first came to long-term care, I didn't realize how much regulations that we have to follow. And if you became an RN, you have a bigger responsibility, especially those critical incidences and reporting, right? But it is very helpful to know what the legislation is, what are the expectations from the legislation we are following our residents. The next portion would be, what are the particular information that you have to know working in long-term care? So I would focus on the core programs, or what are the responsibility of registered staff, RN and RPN in long-term care in terms of your responsibilities, and also what are the skills involved in long-term care and care for the residents. Okay. I think one of the things I wanted to ask you, if I play this video, if you could just probably unmute and let me know if you are able to hear the sound. Hopefully you are. So this would be just a snapshot on what are the process involved when we admit a resident in long-term. What are the expectations of the residents and their family members when they move into long-term care?
Moving into a long-term care home.
Are you able to hear the sound?
Yes.
Yes.
Oh, perfect. Thank you.
Be a challenging, even stressful time. Our home and our caring community of staff, volunteers, and family members are here to make your stay as comfortable as possible. To help make the transition as easy as possible, you'll want to read the Resident's Handbook. It has helpful information about every aspect of the home, including what to bring, medical and personal care, activities and services, and the Resident's Bill of Rights. On the first day, staff will meet with you and your family to review all of your needs, develop a plan of care, and help you become acquainted with the home. We'll record your basic health information, take your photo, and record emergency contact information. Staff will meet with you to discuss your personal financial arrangements and confirm your substitution. The person will make financial decisions on your behalf, unable to do so. If you have a power of attorney to manage your property and financial affairs, please bring the documentation with you. Within the first week, we'll discuss your food preferences and any special dietary needs. We'll review your bathing schedule and discuss the home's programs, services, and activities. Our resident and family support worker will meet with you and give you the chance to share any concerns and ask questions you might have about your new home. If you wish, a pastoral care coordinator will also be available to discuss any spiritual needs you have. We'll also set a date for a meeting with you and your family 6 weeks after you move in. The purpose of this meeting, called the Post-Admission Conference, is to see how you are adjusting to your new home and to review all of your care needs. If you or a family member have concerns or questions once you've moved in, don't wait for the Post-Admission Conference. Ask any staff member for help. The home furnishes your room with a bed, mattress, nightstands, pillows, and bedding. To make your room your own, you'll want to bring some personal furniture and belongings. These items can include a dresser or a small china cabinet or desk, TV, small armchair or reclining chair, comforter or quilt, and pictures for the walls. All electrical items you bring will be checked for safety. Check the residence handbook for a complete list of items not allowed in your room. These include tables, heaters, electric blankets, floor lamps, mats, extension cords, and cooking equipment. Phone, cable TV, and internet services are not provided by the home and must be arranged by the resident. The home provides personal hygiene and grooming supplies and equipment, including things like soap and shampoo, deodorant, toothpaste, brushes and combs, incontinence products, and other toiletries. Our first priority is your safety and security. Safety devices, such as chair, bed, and floor mat alarms, are in place to ensure staff respond quickly to emergencies. Your room has an emergency call bell located at the side of your bed. Your washroom. If you need assistance, pull the cord, and a staff member will respond as soon as possible. All resident rooms are equipped with a smoke detector. The home's emergency plan is tested regularly, and fire drills are conducted monthly. Fire exits are clearly marked within the home. If you hear an alarm, remain where you are and listen to the directions provided by staff. The home is secured with keypad systems at entrances, and some regional homes have secure areas for the safety of residents with dementia. Hand washing is the most effective way to prevent the spread of infection. Hand sanitizers are located throughout the home. We encourage you and your visitors to wash. Meals are served in the dining room 3 times daily. The registered dietitian develops menus based on.
Oh, are you able to hear the are you able to see my screen?
Yeah.
Yes, sir, but
admission
just the
process.
link. Admission
the-
process and a link.
Oh, you don't see the video?
No, sir.
Oh, hold on. Sorry about that. Mm. But were you able to view the entire video or no?
Now, sir, we can see
No, you
the
don't see the
video.
only voice.
Oh, just the voice earlier?
Yeah,
Yes,
just
sir.
the voice.
Oh no, I'm so sorry. Do you want me to repeat or are you okay?
Yes,
Do you want me to start from the start?
I think it's
yes,
Better.
please, if you can.
yes.
Okay. I thought you were able to see the video earlier.
No, sir, just the
My, my apologies.
It's okay, sir. No worries.
Moving into a long-term care home can be a challenging, even stressful time. Our home and our caring community of staff, volunteers, and family members are here to make your stay as comfortable as possible. To help make the transition as easy as possible, you'll want to read the Residence Handbook. It has helpful information about every aspect of the home, including what to bring, medical and personal care, activities and services, and the Resident's Bill of Rights. On the first day, staff will meet with you and your family to review all of your needs, develop a plan of care, and help you become acquainted with the home. We'll record your basic health information, take your photo, and information. Staff will meet with you to discuss your personal financial arrangements and confirm your substitute decision maker, the person who will make financial decisions on your behalf should you become unable to do so. If you have a power of attorney to manage your property and financial affairs, please bring the documentation with you. Within the first week, we'll discuss your food preferences and any special dietary needs. We'll review your bathing schedule and discuss the home's programs, services, and activities. Our resident and family support worker will meet with you and give you the chance to share any concerns and ask questions you might have about your new home. If you wish, a pastoral care coordinator will also be available to discuss any spiritual needs you have. We'll also set a date for a meeting with you and your family 6 weeks after you move in. The purpose of this meeting, called the Post-Admission Conference, is to see how you are adjusting to your new home and to review all of your care needs. If you or a family member have any concerns or questions once you've moved in, don't wait for the Post-Admission Conference. Ask any staff member for help. The home furnishes your room with a bed, mattress, nightstands, pillows, and bedding. To make your room your own, you'll want to bring some personal furniture and belongings. These items can include china cabinet or desk, TV, small armchair or reclining chair, comforter or quilt, and pictures for the walls. All electrical items you bring will be checked for safety. Check the resident's handbook for a complete list of items not allowed in your room. These include tables, heaters, electric blankets, floor lamps, mats, extension cords, and cooking equipment. Please note that phone, cable TV, and internet services are not provided by the home and must be arranged by the resident. The home provides personal hygiene and grooming supplies and equipment, including things like soap and shampoo, deodorant, toothpaste, brushes and combs, incontinence products, and other toiletries. Our first priority is your safety and security. Safety devices, such as chair, bed, and floor mat alarms, are in place to ensure staff respond quickly to emergencies. Your room has an emergency call bell located at the side of your bed. There's also one in your washroom. If you need assistance, pull the cord, and a staff member will respond as soon as possible. All resident rooms are equipped with a smoke detector. The home's emergency plan is tested regularly, and fire exits are clearly marked within the home. If you hear an alarm, remain where you are and listen to the directions provided by staff. The home is secured with keypad systems at entrances, and some regional homes have secure areas for the safety of residents with dementia. Hand washing is the most effective way to prevent the spread of infection. Hand sanitizers are located throughout the home. We encourage you and your visitors to wash your hands often. Meals are served in the dining room 3 times daily. The registered dietitian develops menus based on the Canada Food Guide and ensures that your diet requirements are met. Your preferences and special needs are taken into consideration at each meal. You can provide feedback about menus to the Residents' Food Committee. Please note that food trays are generally not permitted in resident rooms. Any food brought into the home for you should be labeled with your name and the date so that it can be refrigerated by staff. Your medical care is provided by an attending physician at the home. The doctor makes regular visits to the home or can be contacted by the home as needed. If your family would like to meet with a doctor to discuss a health concern, a meeting can be arranged by the registered nurse on duty. Nursing and personal care is provided around the clock and includes assistance with medication and the activities of daily living. Bathing or showering is provided twice weekly. residents have access to a variety of recreational and social activities, including live entertainment, fitness programs, games, gardening, baking, and trips to restaurants and shopping. Our home provides for a range of therapeutic services. An on-site physiotherapist assesses all residents and treats those who need help to function at their ideal level. Other services that may be available at the home include occupational therapy, exercise to maintain independence and mobility, foot care, dental care, eye care, and hairdressing. Staff will mark your name on your clothing in case they're misplaced. The home provides laundry service. However, facilities are available should you prefer to do your own laundry. Please note that dry cleaning and ironing are not available. We recommend that all clothing be wash and wear. Avoid fabrics that may shrink or cannot be machine dried. Also, families are responsible for cleaning personal quilts, decorative pillows, and other delicate items. It's important to note the home's discharge policy. Given the long wait list and the demand for accommodation, when a resident is discharged from the home, we ask families to remove all items from the room within 24 hours. We appreciate your cooperation and consideration of other families in need of our service. The home's Residence Council acts as a liaison between residents and staff, providing residents with a voice on any issues or matters of concern. For homes that have them, family councils provide a similar role in representing residents and working with the administration to explore opportunities to improve the quality of life for all residents. We welcome you and your family to our warm and caring home. The staff and management team want you to adjust and get settled as quickly as possible. Don't hesitate to share your questions and concerns with the appropriate member of the management team. You'll find helpful and supportive staff, volunteers, and family members throughout the home who are more than willing to assist. Again, welcome to your new home.
Okay, let me just go back to my PowerPoint.
Hello, sir. How are you doing?
Okay.
Good. Well, I'm glad to have you back in the clinic. When you were here a few weeks ago, we were looking into some eye problems that you were having.
Sorry about that.
But during that visit, we were also talking about your memory. And you had expressed some concern about your memory. And we did a short test in the office that suggests
Let me just pull out my here, but that is the process in terms of resident moving in to the home. And the video covers quite a lot of information that the family member or a resident needs in terms of transitioning from from the community to long-term care and vice versa. And one of the things that they mentioned is the resident council and family council, which is part of the legislation that the resident needs to have a council in order for them to verbalize their concerns, in order for them to work with the management in the organization to provide care and improve the quality of care, right? council is also responsible for working with the management team in terms of how can nursing and the entire home improve quality of care for residents based on the family's perspective. So one of the things that we have discussed, or I think I touch on, are the required programs in long-term care. And these are expected programs that we need to implement. So the RN and the RPN in the home and PSWs are integral part of ensuring that these programs set by the ministry is being followed. The interdisciplinary programs would be developed and implemented for fall prevention, for skin and wound care, continence, bowel management, and pain management. Each programs would include relevant policies and procedures in terms of evaluating, implementing, and using appropriate base practices. In terms of fall prevention and management program or overview, so the home is expected to have a comprehensive fall management program. So one of the important aspects for staff in long-term care is for us to assess evidence for falls, complete fall risk assessment, and also post-fall assessment. So if the resident, when they came into the home, we need to assess them if they are at a higher risk of fall, medium, or high risk for falls. If a resident had a fall, then we have to complete our fall risk assessment and post-fall assessment. We also do intentional hourly rounding, which for the importance of staff to do their hourly rounds in the entire unit rather. So just a definition, fall is an event that resulted to the person coming to rest inadvertently on the ground or floor or a lower level with or without injury. Okay, this would include resident lost their balance and have fallen. If the staff did not intervene, the resident was found on the floor unwitnessed, or the resident rolls on the floor from the mattress, that is, or the distance to the next lower level surface does not matter, it is still a fall. So in terms of your responsibility, we have to assess the resident's fall risk upon admission, upon readmission. So say, for example, we send them in the hospital and they came back, then we have to do a fall risk assessment again. And following any significant change. So if the resident became sick, unable to do their personal useful activities of daily living, then we have to reassess their fall levels. We also complete a fall risk assessment during admission. So when they came into to the organization or to the long-term care, we have to complete a fall risk assessment. And we also have to do it during readmission and for any significant change. These are requirements, right? We have to do a post-fall huddle. So you have to talk to a few number of staff in a given shift, in a given date, who is responsible for taking care of the resident. And you have to identify the root cause and what are the interventions that we have to that you have to implement to prevent or mitigate the fall. As I've mentioned earlier, these are the intentional hourly rounding responsibilities. So we have to go around the unit and identify if the resident is in pain, if the resident needs peri needs, if they need to be repositioned, and if they wanted their belongings close to their reach, because pain, they wanted to go to the toilet, or they have unmet needs in terms of their continence level. They are uncomfortable and they wanted to reach something. These are the 4 instances when residents fall in long-term care. Not only in long-term care, but in healthcare in general. So what is the responsibility of a registered in fall programs? We have to participate in post-fall huddles. We have to update the plan of care, which we will discuss. Review, report, and post-fall related injuries or post-fall follow-ups, and identify residents at high risk for falls, and communicate during shift. The next aspect that are mandated for all long-term care is that we need to have our skin and wound program. So the skin and wound promotes skin breakdown for any type of skin alteration. So we have to identify residents at a risk for skin breakdown, implement strategies to prevent or manage pressure ulcers, reduce pain and minimize infection, and promote an optimal level of resident function and quality of life. I'm not sure if you're familiar with Braden's score, but Braden risk assessment identifies the level of risk of residents of acquiring pressure ulcer is for any skin alteration. And the pressure ulcer risk score is when assessment, which is, say, for example, when you start working in long-term care, they will also train you to complete that assessment. And after you complete that assessment, you'll be able to generate score. Same thing with falls. You have to and perform skin assessment during admission. And say, for example, you identified a skin impairment, a pressure. The ministry requires up. Again, as per our nursing responsibility, we need to be assessed. But at a minimum, the ministry wants us to have a documentation weekly to identify the trend of the wound. And for residents requiring treatment, then we do another time in point-click care, which I will discuss the mode of documentation in long. You probably have skin tears. Skin tear is a trauma for shearing, friction, or blunt force resulting to separation of skin layer. And this is one of the predominant skin alteration for seniors in long-term care. And it is usually happens during transferring and turning and repositioning because it's very fragile. The skin of residents are very fragile, right? Again, the cause of injuries are wheelchair injuries, accidental bumping, transfers, or sometimes falls. What is the role of a registered staff in skin and wound management? Again, we have to initiate skin and wound assessment, conduct weekly skin and wound assessment, develop and update the plan of care, evaluate the progress of the wound. In long-term care, I think you'll be able to learn more about wounds in long-term care because that is one of the special skills, not special, but general skills that you have to have in your toolbox when working in long-term care. And I've learned quite a lot of interventions and management in wound care because you are working independently on the floor And in order for you to decrease the number of worsening pressure ulcers or worsening wound, then in long-term care they train you to provide basic and complex wound care, which I think later in the presentation we would be able to discuss the trends in wound care in long-term care. Do you want to have a 15-minute break?
No, we can continue.
Sorry?
No, it's fine.
Okay.
You can carry on if you can.
Yeah, sure. The next mandatory program is continence and bowel management. So continence is the ability of an individual to maintain their functioning in terms of bowel and bladder. Because as we age, our continence level might change, right? And again, it depends on the complexity of the resident needs and also their comorbidities. So continence and bowel management, it is an interdisciplinary approach to assess incontinence, promotion of continence, proper use of continent care product, and appropriate toileting routines and evaluation, right? In the hospital, when you start working in the hospital, most of your patients probably are continent, so they are able to go to the washroom. They might need the brief or incontinent product. But in long-term care, it is a norm that the continence level of the resident from the day of admission to say, for example, after 6 months, right, when you reevaluate their continence, it probably have changed. So you need to proper continent product of that particular resident. So continent products are specially fitted for each resident based on the variety of factors. It is important to ensure that each resident is using proper product. So using the wrong type can cause discomfort, skin breakdown, and loss of dignity. In long-term care, the government is responsible for providing funding for continence care. So they give $1 per day for continent product. If you feel a continence product is not appropriate or effective, bring it to the attention of the registered staff or your nursing managers. So this is an example of what we do when the resident goes into long-term care and how do we initiate or change the product. So for 3 days, we review continence diary of the resident. So what does a continence diary mean? So we would have, for 3 days, we would have to identify if the resident is continent or incontinent. If they are incontinent, we have to identify which particular day they are being incontinent. So we would have a resident who's continent during the day, but incontinent during the evening. So we change the product. It depends on the 3-day observation. We also do the toileting plan. So if a resident is incontinent, when is the best time for us to toilet them, right? In the hospital, it might be very different, right? We would probably do our set of rounds and we change their incontinent product based on our rounds. But in long-term care, the ratio between the nurse PSW to a resident might be very different. So you have to identify the set time of toileting of one resident to another in order for you to, number one, save your time, and number two is to meet the needs of the resident. Changing product, it depends on the number one, the assessment. Number two is based on the bowel or bladder diary, right? Which the PSWs or personal support worker documents. And from that on, we base on which particular product they are appropriate, which are appropriate rather. So your role in continence care is to monitor and update the plan of care, complete continence assessment. Again, they will have to train you on which particular assessment you have to complete. Monitor fluid intake, the laxatives and bowel interventions, and report increased laxative use to attending physician or nurse practitioner. Because again, increased use of laxative probably will change the continence ability and control of that particular resident. One of the another program is pain management, which is similar to the previous programs that we have to assess the resident for their pain level before admission, readmission, and any significant change. So again, just to refresh you, pain is whatever the resident says, right? And the challenge for assessing pain of resident is they are cognitively impaired. And self-report is the gold standard of pain, but most of them are cognitively impaired. So we would always rely on nonverbal pain reporting, such as, have you noticed any frowning, grimacing, resisting to certain movement? We had the residents who are resisting during care, like they are kicking, they are verbally responsive during care. We thought it was their behavior, right? Sometimes we would default on, oh, it's probably just the dementia. But when you look at the assessment, when you look at the resident, it might be pain. So we tried giving pain medication before care, and guess what? The behavior decreases. So it's not always behavior, it's not always the dementia, but it could be a different factor like pain or incontinence. In long-term care, if they are cognitively impaired, we use the pain ad. So the pain ad would ask you the four main focus, such as breathing independent of visualization, negative vocalization, facial expression or body language, and also consolability. Right? And then if you answer, say, for example, 2, then it would be 10/10. Right? It could be 0, it could be 5, or it could be 10. Then we complete pain assessment in point-click care for admission and readmission. We also do pain assessment during admission, quarterly, which is every 3 months, annually, and any change in their conditions. So it's not always set for admission every 3 months or every year, but we have to check and complete pain assessment whenever they complain of pain and when we give pain medications. So I'll discuss what MDS means in the next slide. So your role and your responsibility is, again, as a nurse, you have to complete pain documentations, which is the use of PQRST, and any standard and comprehensive pain assessment. We have to update the plan of care of the resident, which is, I think we will discuss in the next few slides. Review PRN usage of the resident in a given week, and complete pre and pain assessment for all pain interventions, including wound care dressing if the resident complains of pain. So in terms of the responsibility of the registered staff, I divided it into three. It's admission, readmission, quarterly, and significant change. So the role of the registered staff, RN and RPN, is to screen for falls, pain, continence, and skin. I think I mentioned skin, right? Skin, continence, falls, and pain, right? It's the same thing too with the RN and RPN. And the PSW or personal, if you're working as a PSW right now in long-term care and in the hospital, you need to notify the RN or RPN for any change in the resident's or patient's condition. If you're already working in long-term care, one of the things that I always ask the registered staff, RN or RPN, is to always update the care plan, right? If you're working in the hospital, because they are short stay, you don't have to do the care plan, right? If you are working, say, for example, in a rehab unit or in a mental health facility like St. Joe's, you have to complete their care plan, right? Care plan is our Bible in long-term care, that we have to follow what is in the care. If you don't follow the care plan, it would be additional citation, right? From the ministry if they would do their inspection. So there's two types of care plan in long-term care. We have the initial care plan. So an initial care plan for each resident would be developed and communicated to direct care staff within 24 hours for each resident admission to the home, right? So it would indicate what are the important things that the staff in long-term care have to know when a resident is admitted in the long-term care. A comprehensive plan of care is assessment necessary to develop a comprehensive plan of care would be completed within the first 14 days of resident admission. And the comprehensive plan of care would be developed within 21 days. So it's a long document, but we try to make it succinct and short so that you don't have to review 23 or 45 pages of care plan, right? And the plan of care includes all things that we have to know about the resident. So say, for example, you start working in long-term care, you don't know everyone, right? You don't know the resident. But in order for you to know a little bit about themselves, how they receive their care is through their care plan. So it includes customary routine, their cognitive ability. Does Mr. Smith able to communicate? Do they need hearing aid? Do they need eyeglasses? Do they have any infection? Do they have any comorbidities that you have to know, right? Any special treatment? So these are important focus that you have to identify and update every new admission and any change in the resident condition. So when to update the care plan? It's through significant change, quarterly and annually. Let's watch a description about
finances, you don't have control of your business. NetSuite Financial Management
care plan.
What is a care plan? What's the one document in a nursing home that outlines all the care and treatment a resident should receive? It's the care plan. Any healthcare provider should be able to walk into your building, pick up a resident's care plan, and know exactly how to care for that resident. Hi, I'm Paige Hector. I've prepared and reviewed thousands of care plans. I'm passionate about care planning because it affects people's lives. The care plan is a document specifically designed for each resident. It's created by an interdisciplinary team composed of doctors, nurses, dietitians, social workers, activity professionals, and all disciplines that support the treatment of a specific resident. Just like a yummy recipe, there are several ingredients that make a care plan great: current challenges, goals, and interventions and approaches. The challenges section identifies the residents' problems, needs, deficits, and strengths. Many folks focus on the residents' weaknesses and forget about his strengths. Strengths are important to address because strengths help people get through tough situations, feel good about themselves, and help resolve their problems. The goals section contains realistic and measurable outcomes. Selecting goals important to the resident is a key ingredient to a realistic care plan. Think of it this way: if it's not important to the resident, it's unlikely that the goal will be achieved. When a goal is accomplished, the resident's quality of life is improved. The other key ingredient for success is making the goal something that is easily measured. The intervention and approaches section outlines specific actions staff can take to help the resident achieve his or her goal. When staff completes or even consistently offers the intervention or action, the resident should be closer to attaining the goal. Remember, the main purpose of care planning is to maintain or improve the resident's quality of life. By creating a culture where the entire healthcare team embraces care planning, care will improve, satisfaction will grow, and residents' lives will benefit.
Okay. So that's essentially what we wanted to achieve in care planning. And care plan is a moving document that we change whenever the resident changes. Okay. The next is care conference. So when you become an RN, there are times that you have to lead the care conference. So every year, or based on the resident needs, we conduct care conference. Care conference is an interdisciplinary team approach wherein we review the residents' needs and how can we better support the needs of the resident. So we include the resident in the conversation if they have a substitute decision maker, and the entire healthcare team is there in that particular time, right? So we would have the nurse, the doctor, the physiotherapy, occupational therapy, a PSW, social worker, any healthcare professionals involved of the care of the resident. And the care conference is done every year and for any significant change. Why is it important? Again, it is important because in order for us to it is important for us to be able to make sure that there is a team approach to care. They help make sure everyone's providing care has the same facts they need, and they help make sure everyone understands the three things: the resident needs, the goals set up to meet the resident, and the plan for reaching the goals. Right? And that is the time for the resident to say, I'm not happy with the care I'm receiving, I want more. Or the resident would say, I'm satisfied, but this is what I want on my care. Right? So this is the time where we also ask the resident and the family about their advanced care directive. Do they want to be resuscitated when we see them unconscious? Do they want to be sent in the hospital? What are the things that we have to focus on to better improve their quality of life? There are different services that we offer in long-term care. So medical services, so we would have the physicians. So sometimes the physician comes in once a week and they are available if we need them. There are times that we have on-site nurse practitioners. They're available during the day and evening shift. And we also have partner hospitals. right? Nursing care services, it's 24/7. That's why we have the RN and RPN. Nursing care services, foot care, podiatry. So foot care is not free, so they have to pay 25 per session, which sometimes they come every month or every other week. Dietitian is responsible for checking their diet and nutritional needs. Respiratory services, so the respiratory therapy is available to assess the residents in long-term care, but they are off-site. So we have to notify the RT whenever they need to come into the home to do their assessment. The BSO services, it's new. So they are responsible for behaviors in behavior management in long-term care. So if the home is unable to take care of the residents' behavior, then we definitely include the Behavior Support Ontario. And dental services, sometimes they come in twice a year or once a year, depending on the contract. And any other services available like pastoral care, social workers, and any other allied health. So I wanted to focus on what is your responsibility as a nurse when you start working in long-term care in terms of medication and medication management. Let me just go back here. Hold on. Let me go to, my apologies about that. Let me just find the video. No, let me go to a different video. So the medication management, the nurses are responsible for receiving medications, ordering medications, medication reconciliation, which we will discuss, and quarterly medication review. So for quarterly medication review, the physician, pharmacist, and review the medication of the resident every 3 months, right? And they would see if the resident are receiving appropriate medications, or do we have to discontinue medications, right? Or do we have to change the residents' the residents' medication or doses? The next focus that I wanted to discuss is medication reconciliation. So a medication reconciliation is a formal process in which healthcare providers work together with patients, families, and care providers to ensure accurate and comprehensive medication information is communicated consistently across transitions of care. So this would be resident from the hospital going into long-term care, or from the community going into long-term care. And we wanted to develop the best possible medication history. So the best possible medication history rather is a systematic process for reviewing residents' medication. So we don't have to miss any medication, and potentially we will mitigate the medication error, right? Because we would review at least one source of medication information. So if you are taking 16 medications in the hospital, we need to expect 16 medications when they go into long-term care. And the physician in long-term care would be able to identify if they wanted to continue or discontinue the medication. I think this is the video I wanted to show you.
When each resident is admitted, we go over the medication policy, medical pharmacy. We introduce it to medical pharmacy. They can meet with our pharmacy consultant if they so choose about the medications. We discuss how we pass medications. We ensure that they don't bring in any medications. Medical pharmacy is our pharmacy, and they're the ones that are to provide the medications and supplies. So there are no over-the-counter drugs here. And even if families, if they're not a prescription or they're over-the-counter drugs that are ordered, they don't bring them in because all medications have to be supplied by medical pharmacy. That's part of our policy. The procedures that we do with our drug administration. Families, we do try to, a lot of families wonder why we have to go through one specific pharmacy and why, if it's an eye drop, can't I just buy it over? It's going to be cheaper if I buy it at Walmart. The problem is with that it's difficult to control. If families are in visiting and they're giving eye drops and we've got an order for eye drops and we're giving eye drops, then you're double dosing. So you don't want anybody else giving medications to the resident, not even the family members, because you can't keep track of it. There is a rationale that we have to put beside why they're taking the medications, and then we phone the doctor, the admitting doctor here, and go over the medications that the resident has come in with, and then he'll decide from there if he wants to keep her on the certain medications or discontinue some or change some. And then he does the physical on the resident, and that's where he takes over the care.
So that is how the medication process in long-term care looks like. The nurse was able to summarize it to us. And it might seem a lot of work for you, but when you start getting the groove of it, and you know the processes in long-term care, it would be just a walk in the park for you, but you just have to follow the required checks. Medication is I would say about 50% of the time that we allot in long-term care is giving medications. Not only giving medications, but following the process of medications. It's not only the act of administering the medication, but the process involved in ensuring that we provide appropriate medication and medication safety for our residents. I wanted to show you because some homes start using an automated dispensing cabinet, which decreases potential errors in medication administration and dispensing.
Installations for several months. You have talked with directors of nursing, facility ownership. Tell me what you're hearing from Sheila.
Sure. Most of that they're enjoying the most is like accountability for the equipment, because medications typically were stored in tackle boxes, and then they have double sets of tackle boxes also, so they have double inventory. This way they don't have to have double inventory, they have to swap them out, and they don't have to do all the time it takes to track for missing doses that nurses did not sign out. So it's a lot of accountability, affordability, because you don't have this double set of inventories.
You talk about frequently hearing about what could happen with the manual tackle box. Would you say most people working in a facility nursing would have experienced one of those in person? A missing med, lock busted, paperwork for billing missing. Has every nurse experienced this? Which I'm not.
Right, nurse and pharmacy, obviously, because we're dealing with controlled substance sometimes, well, almost lost charges. So we want to make sure that we're more secure, where we can track and trace everything. And the tackle box doesn't just go missing, because Nexus isn't going to just go missing.
When people go from the manual process, the tackle box they've used for years, and they bring in the Nexus ADC, is it an immediate, why didn't we do this before? Or does it take some getting used to losing the old familiar tackle box system and going to something electronic?
Sure, sometimes technology scares people. So one thing about Nexus is very simple and easy to use. So they can log in once they're in. If they select their patient, select their medication, it dispenses medication for them. So once we get over that fear that someone might have, they do find it to be very easy. And the medication's waiting to be used instead of the nurse waiting to get the medication.
Last question in two parts. The coolest function that people have told you about Nexus ADC, the pharmacy's perspective, what's their number one thing where they're all saying, I love this?
Accountability. They know where the medications are, what happened to them and who used them, and what patient had them.
And then nursing.
Nursing, they know the med's there waiting for the patient instead of the patient waiting for the med. You know, sometimes you're dealing with a family member who's more aggravated than the patient might be because they're waiting to get the medication for their loved one.
Thanks, Jody.
Thank you.
So the Nexus cabinet that the lady was talking about it's an automated dispensing cabinet wherein same thing with the automated dispensing cabinet in the hospital, wherein if you wanted a medication, you just have to log in the computer in the machine and it would dispense the medication that you want. Okay. The next is point-click care, which we will discuss in this slide. This is an example of a point-click care dashboard. So all documentation in long-term care is electronic, except for other, it depends on your hospital, and it depends on what you track in point-click care. So point-click care is the main software that we use in long-term care. It's similar to Meditech or any other software from a healthcare facility. So it would have the resident's name, information here, allergies, and these tabs constitute different functionality. So say, for example, if you wanted to check the medication profile of the resident, you go to orders. If you wanted to chart progress note, you go progress note and write your own documentation. If you wanted to do your assessment, then you have to go to assessment section, which is very intuitive. And now there's a lot of functionality in point-click care that is very useful in saving your time and saving resources, right? Mostly paper, because it would prevent you from flipping from the paper chart, and it gives you considerable amount of time. We also have, again, you have to do your assessment like skin and wound, pain management, behaviors and responsive behaviors, because again, residents in long-term care, most of them have cognitive impairment or dementia. And one of the required training that you have to do in long-term care is what we call gentle persuasive approach, or GPA. And this is one, what you're going to see is only one aspect of GPA that they teach you in order for you to, if there's any responsive behaviors, that you'll be able to mitigate and safely remove yourself from the situation and also the resident whenever they have responsive behaviors.
My restaurant opens in a few hours and I'm still a dozen short.
In some instances, you may need to redirect a person from a situation of risk or move them to a safer area. As with any approach, ensure you are using respectful communication. Say the person's name, let them know who you are, and use validation. Using the individual gentle redirection technique, you will be approaching from the side. Use your outside arm to grasp the wrist of the person's hand closest to you. Since I'm approaching Mario from the right, I'm going to use my right hand and place it onto his right wrist. Likewise, if I were approaching him from the left-hand side, I would use my left hand onto his left wrist. When grasping the person's wrist, ensure that your palm is face down and that your fingers and thumb are encircling their wrist completely. Moving their arm in a downward and outward motion, move your free arm underneath their armpit. This creates an anchor or a lever effect. Prepare to react with your inside arm should the person respond with their free hand by trying to strike you. If their hand comes within reach, use your free hand to grasp their wrist. Apply your hand in the same palm down position with your fingers and thumbs encircling their wrist. Gently hold the person's arms outward and downward toward your body, with your hip tucked in slightly behind and to the side. Be mindful of the person's mood and their cues to their behavior to avoid further strikes or elbows to your head or chest. In this position, it is easier to redirect the person to a safe place. At any time, you can change this to the stroll technique by releasing their arm furthest from you and placing your free hand on your own wrist. You can use the stroll technique to walk with the person and continue to help them to de-escalate. Be mindful of further potential risks and adjust your plan accordingly. Mario, you seem upset.
I am.
Would you like to go down to the lounge and we can talk?
That sounds lovely.
Hi, Alex.
Hi.
I just wanted to let people know, if you're interested with GPA, it's very useful for any setting that you're going to be working at. You can check Alzheimer's Society in your city, and they do provide trainings. I've attended before. It is in person, but now they're doing it online. I believe you have to pay $50 for it. It's a training online. It's really good. It's worth your money. And they also provide you a manual for it. So,
Okay, ma'am.
Yeah.
Thank you.
Thanks, Lourdes. So as Lourdes mentioned, they provide trainings for GPA. And it's a very good, it's very useful, especially if you're working in senior setting. And if you're going to ask me if I've used those techniques, I did a couple of times because of responsive behaviors, right? You just don't want to run to avoid those, but you have to make sure that you are protecting yourself and also the resident. One of the skills that we also do currently in long-term care is hypodermoclysis. So a hypodermoclysis in the hospital, if a resident is not eating, the resident needs hydration, we initiate intravenous infusion. But in long-term care, we mostly use hypodermoclysis in limited situations. Number one, through intermittent hydration. So if the resident has not been eating for 3-4 days, then we initiate hydration. Or if the resident is on palliative care, then we initiate hydration. But this is very, very used in a very time-limited situation. So it's only used for 72 hours, and then the physician have to reassess. But this should not be a long-term approach for hydration. So we use different sites. It could be lower, middle, third, or inner or outer aspect of the thigh, lateral aspect of the abdomen. You avoid the waist level because that's where you put the pants. The pectoral area, usually the chest wall, lateral to the breast, intraclavicular site, 3 centimeters beneath the midpoint of the clavicle. And it is, in terms of the flow regulation, it's only limited to 50 to 80 cc per ml. And we have to change the infusion site 72 hours, or if there's any complication. So if you see any swelling or edema, you have to change it even before 72 hours. So if you're not familiar with hypodermoclysis, let me just share to you this video, which would be very useful.
I needed an online store for my jewelry design business, so Shop Here powered by Google.
In this video, you will see how to use the Safety Intima
24-gauge subcutaneous needle by BD Canada. To get started, gather the following equipment: Safety Intima 24-gauge subcutaneous needle, Baxter 1-link caps, SoluPrep chlorhexidine swab, 3M Tegaderm IV Advanced 1683 securement dressing, non-sterile gloves, and pre-filled 3cc syringe. Ensure you check your patient's armband and have them verify 2 identifiers prior to starting. Select subcutaneous injection site based on your assessment of your patient. Don non-sterile gloves, cleanse site with the SoluPrep chlorhexidine swab for 30 seconds and allow for adequate drying time. Prepare Safety Intima subcutaneous needle by rotating the white safety shield 360 degrees. Ensure the bevel is up and the catheter is not extended over the needle tip. Pinch the yellow wings together, texture side down. Gently pinch skin fold. Insert the subcutaneous needle on a 30 to 45 degree angle and ensure you insert the needle to the hub. Firmly hold wings flat on the skin with non-dominant hand. Pull back with dominant hand on the white safety shield and remove needle. Apply 3M Tegaderm IV Advanced 1683 securement dressing, ensuring that you see the insert.
Hi, Alex, we lost the sound.
Attach primed Baxter 1-link cap and flush with a pre-filled 3cc syringe to insert 0.28 cc's of fluid into the line. Note that this device cannot be pre-primed, and this is of no harm to the patient. In summary, here are the important points to remember. Rotate the white safety shield to loosen needle. Ensure the needle bevel is up and the catheter is not covering the needle bevel. With texture side down. Insert the needle at a 30 to 45 degree angle to the hub. Secure set with 3M Tegaderm IV Advanced 1683 dressing. And document the subcutaneous insertion into the medical assessment intervention.
So that is a very important skills that we frequently do in long-term care, which is hypodermoclysis. Again, you're not obligated if you don't know to perform this procedure. During orientation or whenever you have to do it, you just have to ask your educator or your director of nursing to help you or assist you. let me just show you how automated dispensing cabinets work. I showed you the previous video, but unfortunately it was the incorrect video, so I apologize on that. So I'll show you how oh, it's a bit the same. Dispensing cabinet, as I've mentioned earlier, it's if you're going to type in the medication in the computer, and it will discharge, or it will dispense the medication that you need. You might be able to see fecal management system, which we started to have residents who have chronic debilitating diarrhea because of chronic inflammatory disease in their bowels. So a fecal management program is a rectal tube it's a rectal tube system that enables the patient to continually have bowels running like in the collection bag, and the staff have to change there's the system as ordered by the physician. I'm not sure if you had an experience with VAC dressing, but long-term care now start receiving VAC dressing. I'll show you quickly how a VAC dressing is. So a VAC dressing, number one, is a little bit costly. So we try to limit the use of VAC dressing, but if a resident needs VAC dressing, then we have to initiate the purchase and continuous use of VAC dressing. If you're unfamiliar, I'll show you how it looks like. But before you operate a VAC dressing machine, you need to have knowledge, skills, and judgment in operating a VAC machine.
Hello, I'm Chris Shettle, Certified Wound Care and Hyperbaric Specialist. In this video demonstration, we'll see how to apply the VAC therapy system dressing on a typical wound. As you can see, this patient has a wound in the sacral area, which requires a standard VAC dressing. Let's see how to apply it. Begin by assessing the wound size and type, and prepare the wound bed according to institutional protocol. Next, cut the dressing to fit the size and shape of the wound. Make sure it's not placed over intact skin. Gently place the VAC dressing into the wound. Do not force the foam dressing into any area of the wound. It should not be overstuffed with foam. Peel back one side of layer 1 and place it adhesive side down over the wound. Then remove the remaining side of layer 1, the green stripe stabilization layer 2, and the handling tabs. Choose an appropriate location for the SensaTrack pad. Pinch the drape and cut a 2.5 centimeter hole through it. The hole should be large enough to allow for removal of fluid and exudate. You do not need to cut into the foam. Next, remove the backing layers 1 and 2 from the SensaTrack pad. Place the SensaTrack pad opening directly over the hole. Pull the blue tab to remove the stabilization layer. Record the dressing change date and the number of foam pieces used on the foam quantity label and place it in the patient record. It's important to also document on the dressing itself the date, your initials, and the number of foam pieces. Connect the SensaTrack pad tubing to the canister tubing. Ensure the clamps are open. Turn on power to VAC therapy unit and set the system to the physician prescribed setting to initiate therapy. So, as you can see, a typical VAC therapy dressing is easy to apply and is suitable for patients with a wide variety of wound types, sizes, and shapes. For more product demos and helpful application techniques, visit acelity.com.
So just a disclaimer, I'm not endorsing anything. Those are just helpful videos, just to give you an overview. But you need to have knowledge, attitude, and judgment to operate a VAC machine. And we don't often use this, but again, nurses in long-term care are very skilled in managing comprehensive, complex wound, especially pressure ulcers. One of the areas that because our residents are becoming more complex, right? And we sometimes have to admit a resident who is receiving CAD pump, or who is receiving, not CAD pump, who's receiving intravenous, either continuous or intermittent infusion of antibiotics, or I think mostly antibiotic, right? that cannot be given through IM or IV, or IM or oral, right? So that's why we use CAD pump in terms of providing intravenous therapy. PICC line dressing, if a resident comes into the long-term care with long-term therapy, or say, for example, they go to the hospital for intermittent chemotherapy or intermittent blood transfusion, then we maintain the dressing of the PICC line, but we are not responsible for removing the PICC line, but our responsibility is to identify if the PICC line is dislodged. Or how would you identify if a PICC line is dislodged? So you will be able to see, because we measure it every PICC line dressing change, right? If there's, say for example, if the line is 16 centimeters, and the next week you measured it 18, and it becomes 20, 20, 25, then it is your obligation to notify your healthcare provider that there's a possibility of dislodgement of the PICC line. Some trends and issues in long-term care. As you know, long-term care is one of the areas that that was inundated by COVID-19. Lessons learned from the COVID-19 from last year is we have insufficient staffing. There's more. Before the pandemic, the hospital had a mandate to decant hospital beds, and they transferred a lot of patients in the hospital that requires ALC transfer, or residents who require a very complex nursing care. There's limited infection control practices in long-term care as identified by the ministry report, and families were unable to contact or unable to visit their loved ones in long-term care. So the changes they made in response to those findings is to increase staffing. So there's more nurses and PSWs that they need in long-term care, better admission and discharge. We are partnering more with our hospitals to take care of the level of complexity of residents in long-term care, and family members, regardless if a home is on COVID outbreak, family members, especially essential caregivers, can still visit their loved ones. So I'll just focus on some here. I wanted to focus on the questions. So let me just choose which particular areas I wanted to focus on in the last remaining slides. Let me go to skin and wound application first.
If you're a coach, consultant, or agency owner, and your calendar looks like this, I'll show you to get your calendar to look like this, or you don't.
Beth is a long-term care nurse. Her facility star rating recently dropped from a 4 to a 3. This in turn reduced the number of referrals sent to her facility from a neighboring acute care center. When Beth's facility investigated the cause of their ratings drop, they found that their MDS submissions to CMS had an increase in pressure injuries. Beth's facility decided to immediately address the issue and implement Point-Click Care's skin and wound solution. Before using Point-Click Care, Beth used to measure wounds by hand, take an average of the 3 measurements, and track the wound progress using paper and Excel. Sometimes Beth's measurements didn't line up with what her coworker measured at the last wound assessment. which meant Beth had to spend time investigating and getting a hold of other care team members. Now that Point-Click Care's skin and wound solution is in place, Beth is very happy. She and her coworkers are able to easily and consistently measure wounds. Beth uses her iPhone to take accurate measurements and easily record all information into the EHR. No more paper or Excel for Beth. And to top it off, she can easily see how the wound healing is trending. No more inconsistent measurements. Lucky Beth. Before using Point-Click Care, Beth often had to go through the lengthy process of unwrapping the wound for visiting family members who wanted to see the injury. This constant wrapping and unwrapping of the wound means her facility is paying for expensive treatments being reapplied. And sometimes wound healing is delayed as a result of the repeated exposure. Now that Beth is using Point-Click Care's skin and wound solution, having family members see the wound is easy. With a quick slide of the finger, Beth can show them a series of images that show how the wound is improving, all without disturbing the resident. Before Point-Click Care's skin and wound solution was a part of Beth's life, sharing information with care team members outside the facility used to be a series of phone calls, voicemails, and lengthy conversations. Sometimes care team members would even have to drive to the facility to see the wound. With her new skin and wound module, Beth is now able to share wound information quickly and easily with care team members outside her facility. A quick text from Point-Click Care's app alerts a team member to a change in a resident's condition. Once logged into the Point-Click Care EHR, Beth's team members can see the wound as it appears now, compare it to past images, and easily place an order to adjust medications, all without ever visiting the facility. It's a far cry from the late-night telephone tag Beth used to endure. Before Point-Click Care's skin and wound solution was a part of her life, Beth used to end her day taking all of the pieces of paper with notes and wound measurements from her rounds and enter them into her computer. It used to take an hour every other day, which was time Beth would rather have used to engage with her residents. But all that is a thing of the past. Now all of the data from Beth's rounds is automatically uploaded securely into the Point-Click Care EHR. Beth no longer spends her time creating spreadsheets for Amy, her director of nursing, and Amy no longer spends 8 hours every month consolidating Excel spreadsheets from all of her staff and facilities. Now, Beth and Amy are so much happier, and so is the facility administrator.
So that is the one functions that we now is using in long-term care. I like the application because it's able to provide us a clear picture of the residents' wounds. And say, for example, for me, one of my portfolio is skin and wound in the organization. So I oversee 8 long-term cares. And I just go into skin and wound application in Point-Click Care, and I'll be able to see the different wounds of residents. And that is one of the advancements that we invested to better provide number one, efficiency for nursing staff, and number 2 is that for better tracking. There's quite a lot of things that I wanted to include in the presentation, but those are the central information that you should have when you start working in long-term care, because those are the core areas that you do in a given day. I've been working since 2012 in long-term care, and a day in a life of a long-term care nurse changes every day. It might be, you might have a lot of downtime giving medications, doing your expected assessment, but there are times that it might be very crazy, right? You might have 2 admissions coming in, you have resident who had a fall, you had a resident not doing well, and there are times that you felt like you're very fast and very busy, but there's a lot of resources and support. Let me see. Let's check the questions. Also, quite a lot of you are working in long-term care. Work as the recreation department, good. So some of the question is how to apply for a job as an RN in long-term care. Is there a long-term care in Nova Scotia? Each provinces and territories have long-term care, but they work differently in terms of the legislation. You can apply if there's an opening in long-term care. In Ontario, there's a high need for RNs in long-term care. Not only RN, but RPN. Hospitals have RNs posting, long-term care have posting. You can go to Indeed and search for any opening, or you can go to individual organizations, because they are, again, there's a higher need for RNs in the province. What is the salary range for RN and RPN? Each organization have different rate in terms of RN and RPN or LPN salary. So in the hospital, might be a little higher because of the complexity. But in long-term care, it depends on which home you're working at. If you're working in a municipal home, so it's run by a government home. So say, for example, run by the city of Hamilton or Toronto or Niagara, or Halton region or Peel, then your base salary is higher, or hourly rate is higher than private homes, but it's not significantly higher. I cannot give you an exact amount because it changes from one organization to another. What are the criteria for the selection of nurses, PSWs, in so for PSWs, if you are an internationally educated and you have been assessed by the College of Nurses, and your application is ongoing, you can apply as a PSW. So some organizations waive the PSW certificate if you are currently being processed by the College of Nurses. So you just have to show them the documentation that you are waiting for your registration as an RN or RPN. But there are organizations who, even if you are currently being assessed by the College of Nurses, there are organizations still require you to have a PSW certificate. It depends on which organization. I cannot speak to all the organizations, but that is the two ways they do in terms of screening PSW applicants. I heard somebody, does anybody have a question? Oh. In terms of nurses, we generally, for RNs and RPNs, if you're a new grad or you recently got your certificate or registration from the college as an RPN or RN, we don't set a minimum number of experience. All new grads or new nurses are welcome to apply in long-term care. One of the things that we look at is your experience as an asset, your education an asset, but as an IEN, say for example, you didn't finish RN or RPN in a college or university in Ontario, but you get your registration from the college, they still will hire you, right? Because you have your registration. And when I was an RPN, I didn't do my bridging here as an RPN. Since in 2012 as an RPN, and I applied in one long-term care, I was able to get a job as an RPN, right? But right now, because of a nursing need, if you apply for, say for example, 12 long-term care today, you'll probably expect to get a call for 12 long-term care in the next few days or weeks, right? What is the patient-nurse ratio in long-term care? It depends on which organization you're working at, right? So ideally, if you're an RN, you're the charge nurse for a particular unit or a building, right? So say, for example, if your home have less than 100 beds, there would be one RN in the building, but there would be other RN in the floors. So probably you have 4 units. You might have 2 RN as a charge nurse, and you have 4 RPNs working on the floor, right? Other organization, like in one of our homes, we have 216 bed. We have 5 RNs during the day, which are 5 charge nurses, and you have a few number of RPNs. So as an RN, you are the charge. Don't give meds, but you oversee the operation of the unit or the building. Shivana mentioned about what is MDS-RAI. So MDS is a data system, which is an assessment that looks at the general functioning of a resident, right? And based on the results of the MDS, we get our funding. So if our MDS score is very high, the complexity of our residents is very complex. So the government will give us more funding. Lourdes asked about what courses would you recommend to someone who would like to work or who would like to prepare and pursue employment in long-term care. So as an IEN, one of the things that I did is care was very helpful in terms of language proficiency and language skills. So I remember taking the LIN language, I forget the name of the course, Lourdes, but it's a course is intended for IENs who wanted to work in the clinical setting. So we would have some mock activities about when to give transfer of accountability, what are the things that you have to include when you're giving. I did because at that time I was new in Canada. So I have to take medication administration course. I also have to take physical assessment course because that's part of the expectation from the job description when I signed up as an RAN in RPN rather in an LTC home. So those 2 plus the courses that CARE offered, which helped me transition. If you don't have a GPA training prior to entering a long-term care home, your employer will give you GPA training and they get you certified too. But because of the pandemic, we do it online. They also would, sometimes your employer would pay for your CPR certificate or CPR training. Hello, I'm currently working in an LTC and I must say the presentation today. Oh, thank you so much. These are the things I wish I was taught when I started. It wasn't a pleasing experience. Thank you so much. Thank you for the feedback. I appreciate it. And I'm currently in the organization that I'm currently working at. We wanted to improve the orientation process for nurses, and we provide a better orientation of what are the things that the RPN or RN when they're providing care to long-term care residents. Can the VAC dressing be done by any nurse or wound care nurse? Yes, as long as you were given the training and have knowledge, attitude, and skills and judgment. If you are uncomfortable to operate the machine, alert or whenever the system beeps, you have to notify the nurse practitioner, because sometimes we have nurse practitioner inside, or we have the wound care nurse. Milena, did you raise your hand?
Yes. First, thank you very much for the presentation. It was very informative. And I would like to ask, I'm an international educator nurse. I don't have a PSW certificate, but I would like to look for a job as a PSW. But yeah, I just would like to know what courses do you recommend there for PSW, like not for PSW, for getting a position as a PSW, and how to prepare for interviews?
Yeah, I think first some interview training. Let me defer that to Lourdes. Or probably Lourdes or care staff can follow up with you.
Is it for the interview?
Yeah.
Oh, so like a mock interview? Yes, we do have, I believe in September, we are going to do a 3-day kind of like a job interview preparation. So the last part of it will be a mock interview. So we will be actually a few employers already agreed. There's not going to be a hiring process at this time, but these are real employers who hire IEN, so they could give you feedback. So after your mock interview, they'll give you a feedback afterwards, what you did well and what you need to improve when it comes to interview. So it's really good because you're hearing it from somebody, not just from your case manager, but from someone who hires IENs, and they could give you valuable feedback on your performance. So watch out for that. We'll be circulating the flyer soon. So that will be sometime in September. So anytime you do have also questions regarding employment and other opportunities within your area, please connect with your case manager. Don't forget them because they're there to support you. Just connect with them and they will provide you resume, feedback as well before you apply.
Thank you, Lourdes. And the courses that I attended to at CARE before was very helpful in preparing me when I was very fresh off the boat rather, fresh off the boats in 2012, because I gained more experience, right? Even if your English is your second language, sometimes your nerves and your nervousness sometimes changes the way you think and the way you enunciate words.
I'm sorry.
Sorry?
I'm sorry, I do have another question, if you don't mind. Yeah, and since I don't have a PSW certificate, I think you mentioned that some long-term care facilities, they hire international nurses without PSW certificate. But yeah, like I'm wondering if is there like any courses that will help me to get a position since I don't have a PSW certificate?
There are homes that requires the certificate. There are homes that doesn't, as long as you provide them documentation from the College of Nurses that you are being assessed for RPN or RN, right? I'm not sure of any course that provides training for PSWs, but there are schools that offers that certificate.
But it's just costly. I mean, like if you have safe practice to do for RN, RP, just kind of like save your money for PSW program. Try to network. That's one of the things too that a lot of people get jobs. It's like somebody that they know of. So that will be good as well.
Yeah. Thanks for that. I'm not a DOC. I used to be a DOC, but I'm currently a nurse consultant. So I oversee 8 long-term care, 8 government homes. Is there a prescribed RPN or resident to RN ratio by the ministry? There's no set requirement by the ministry on how many RN and RPN in terms of RPN to resident ratio. The minimum requirement is there need to be an RN 24/7 who is not part of the management 24/7. So it is up to the organization to mandate how many RN and RPN per resident ratio, right? So it could be 1 RPN to 35 residents, 1 RPN to 40 residents. But the union, especially ONA, mandates a required number of RN hours in a particular facility. What is the role of PSW? As I've mentioned earlier, personal support workers are responsible for activities of daily living for residents. Assisting them with bath, assisting them with eating, feeding, toileting, transferring, right, pericare, and also social support. It's very informative, detailed. Thank you so much for the feedback. Raja, did you raise your hand?
Yes, sir.
Yeah.
Sorry. Hi. For me, I got received a job offer as preposé au bénéficiaire in Francophone side. It's like kind of personal support worker. The thing that I applied already in NNIS for the registration. Okay. I would like to know if there are any courses which will help to minimize the bridging time or to minimize the waiting for the licensing. Sorry. And thank you for all the information. Thank you.
Your question that you have to take in order for you to decrease your waiting time for your assessment or licensure, is that correct?
License, yes, sir.
So did the college gave you authorization to write or assessed you with that your program or your application is comparable?
Sir. I did the WES. I sent my papers and I'm waiting. I applied already for the NNIS, but still I did not receive any comparison. No, not yet. The assessment not yet done.
I think the best way for you is to wait for what the college, because there are times that if you take courses, additional courses, right? They probably would say, for example, would give you eligibility to write, or they will direct you on what are the next steps that you have to do. It depends on the assessment. And your case manager would help you, CARE would help you navigate ways to get your registration. And again, CARE
is very helpful.
Yeah, CARE was very helpful in navigating my sister and my brother-in-law's application. So I'm grateful for that.
Me too. Thank you so much. Thank you.
Anita, did you raise your hand? You're welcome.
Yes, sir. Could you please give us today's slides because it's very important and I need to go through again. There is a link, important link, and everything is today class is very important.
Oh, sorry, what was that again?
Could you please send us the today's slide that has all information that we see today? Because we need to again go through those slides and links. So.
Yeah, for sure. That's not a problem.
I think that the presentation, the whole thing will be on the only members website. I have to check with Michelle about that because we usually post it so individuals can still watch it. I'm not quite sure about the presentation stuff. I'm not sure. I have to ask Michelle about that. But we'll let you know. So we will email you guys on where you can get this information.
Thank you, Lourdes. Sybil mentioned horror day in long-term care when you're when PSWs, then the PSW called you because of your resident fall. Again, even if you're working in long-term care and the hospital, you would have those days, right? But one of the things that I've learned all throughout my career in long-term care is that there's no how we look at things, right? We always say it's a bad day or it's a good day, but essentially any day could be acute because residents' needs have been becoming complex, right? So one of the things that I always do is that I plan my day, and there's always an RN or a charge nurse if you're working as an RPN available. If you're working as an RN, there's always a charge nurse and RPN who can help you, or PSWs, right? It's very helpful for you to adjust in your role when you're giving 35 residents their medication and you're late because of an emergency. PSWs would help you, right? RNs would help you, and there's always resources available in long-term care. That's why relationship is important, right? Being civil to one another is very important too when you start working in long-term care. And on your first day, and you say, "Hi, I'm Alex, I'm the new RN or I'm the new RPN. Can I get your name?" Because one of the things that I learned is that we need to, for me, especially that whenever I ask for their help, I always say, "John, can you please help me?" Because relationship is very important. And that's what the College of Nurses wants, right? To build professional relationship. Great. Thank you so much for the feedback in the chat. Do you have any question? Just feel free to unmute yourself.
Great presentation, Alex. Really good. I'm happy that I was able to join today. Learn a lot. It's like going back to my basics again. It's really good. So let's all give Alex at least a thumbs up, or on your reaction button there, thumbs up or even a clap. You really did a good job today.
Thank you so much. Appreciate it. And I'm happy to meet all of you in virtually, given these situations. But I would be happy to meet you in person soon.
Any last questions? I just wanted to, before you go, Alex, September 16, we're gonna have like a graduation, and also Tuesday next week, there will be another presentation, and this is now with William Osler. For anybody who's interested to learn about dialysis, or at least learn of what courses you have to do and prepare yourself, that will be a good chance. So you still have until end of the day to register, even on Monday. The sooner the better for you. Yeah, so we'll see you again on that one. Alex, really, really great to see you again. Thank you for sharing your knowledge with us. It's a pleasure hearing from you, one of the successful IENs that we have that now is supporting other IENs, which is really, we're proud of you for doing that. You never forget where you came from, right?
Yeah, I think it's a humbling experience to that with I have CARE on my journey, and CARE was, again, I'm always thankful because they were able to help my sister and my brother-in-law with their registration, and so thank you, CARE.
It's true. Yeah. Both of your brother and sister now, brother-in-law are now going to be RN soon, so yes, it's really good. The whole family now, right?
I know.
Yeah.
He's part of the CARE and UHN program.
Yes, project. Yes. So some of you knows about that we have the project for safe practice. Yes. So he just completed that one. So he's on his way now to registration to an RN, right? So yeah. So there's a hope, right? So don't ever lose hope. If people have done it in the past, you can do that too. Just it sometimes takes a while, right?
Yes, I think there's hope and there's care. So that's that.
And then you just, pay it forward to help other people along the way as well. Once you already, move up a little bit. So always do that. Support each other. Okay, no other questions. So they're all saying thank you for your time and for sharing your experience and They're very proud of you, according to Sybil. Yes. So again, anything else before you go? It's a good timing. You're 5 minutes early.
Thank you so much.
Thank you, guys. Somebody's asking about the name of the next orientation. That is for the Meet the Employer, William Osler Health System, so WOHS. That will be next Tuesday at 2 to 3 p.m. Please join us. It will be great. Again, it's a chance to ask questions to employers and learn from them. Okay, take care, guys. If you have any other question regarding other workshops that we have, please connect with your case manager as well as with Emmanuel and COSAR. Hope to see you guys on your, can you just show your face for the last time? And then before we go, do we see everybody here? Perfect. Thank you so much, guys. We'll see you again. Good that you're here. Hopefully, I'm sure you got a lot of information today. Thanks again, Alex.
Bye. Thank you so much.
Bye, guys.